Dr. Edward Shaw, welcome to Shrink Wrap Radio.
Thanks, David. I'm honored to be on your show.
Well, I'm honored to have you on the show. You're one of three authors of this book, Keeping Love Alive as Memories Fade, the 5 Love Languages and the Alzheimer's Journey. And so I'm really glad to have you on the show because Alzheimer's is on lots of people's minds. You know, there's a lot of fear out there about it. It's something that I've been afraid of. I'm too old now. The one relief I've had is I realize I'm too old for early onset Alzheimer's. So if it comes along, it will be in a slower way than that. And there are 3 authors in the book, as I mentioned, but I wanted to speak to you because your perspective kind of drives the book in as much as you were caring for your wife who had Alzheimer's, which began for her at age 53. And I understand she just passed away 3 months ago. So
She did.
Yeah. So that's very fresh. And, but I gather you're still up for sharing your experience with us.
I am, David. Ever since Rebecca was diagnosed, I think for her and our 3 adult daughters and me, we've wanted her journey and our journey to be somewhat public. Because we found when Rebecca was diagnosed, we had a diagnosis here at Wake Forest Baptist Health where I work. Our doctors said, I think you should get a second opinion. 53-year-olds without a family history shouldn't get Alzheimer's disease. So I went back to where I trained. And in fact, my former next door neighbor, Dr. Ron Peterson, is the world authority on pre-Alzheimer's disease and early onset Alzheimer's disease. So we knew him personally. He knew Rebecca.
Wow.
And so we got a second opinion from him. And I felt as though we had some of the best doctors in the world caring for her and giving us a diagnosis. And yet, when she was officially diagnosed, the girls, my daughters and I felt like, you know, your mom, your wife has a progressive, untreatable, incurable neurodegenerative disease. Have a good day. And it really wasn't like that, David. They were kind and compassionate doctors, but there were no resources for the emotional journey. And we are a very close-knit family. And from the moment the diagnosis was confirmed, there was nothing more important to me than to keep the loving relationship I had with my wife of then 33 years as she went through this disease that would take her life early. And
wow.
That's really the birth of a career change and the idea for the book.
Yeah, speaking of the career change, we'll get into that. Let's back up just a little bit because you are a medical doctor. So tell us what your career was up until that event.
So my original training was in the field of radiation oncology, so a cancer doctor. And I've always worked in an academic setting. So I trained and began my career at Mayo Clinic and then came to Wake Forest. And my primary interest was brain tumors, both in adults and children, and had really become, and I say this with all humility, but had become a world authority in the diagnosis and treatment of adults and kids with brain tumors. And my area of research has always been cognitive function in cancer. So how do brain tumors and the treatments for brain tumors, or even just the treatments for lung cancer or breast cancer, how do they affect memory and other cognitive functions? And so
in some sense, you were set up ideally for, from a cognitive point of view, for understanding something about this tragedy, about how the brain works and so on.
Yes, and so when my wife began having symptoms, it was a big uh-oh moment because I recognized that the memory loss and difficulty learning information she had was not normal for a 53-year-old with an IQ of 145 who graduated in the top 0.1% of her class.
Wow. This reminds me of the movie. Was it Susan Sarandon? It's not her. It was a movie.
Yes.
Help me. Do you remember the
Still
title?
Alice is the book in the movie.
Still Alice. Yes.
And it was, I haven't seen the movie. I read the book only because, I've lived the movie day to day for
Yeah.
9 years. And, but it's the book is a very well-written book by a neurobiologist who portrays in a very realistic way what the early symptoms are and then the progression of the disease for its natural history.
Yeah. Did you say 9 years was the
9 years?
Okay. And what were you the first person to notice that there was some cognitive loss, or was she?
She was actually the first person. She had some disorganization that my oldest daughter, Erin, noticed while she and her mom were planning for Erin's wedding. She noticed that her mom was uncharacteristically disorganized. And it kind of was a head scratcher, but we didn't think too much of it. She would have some short-term memory slips that we didn't think too much of. But I remember very vividly, we were sitting at the kitchen table in the year that she was ultimately diagnosed, and she was reading the old print version of U.S. News and World Report. And she looked at me and she said, "Ed, I have read this article 3 times and I can't remember a single fact about it." And that was really the first clue that, maybe something more is going on that we were just casually dismissing as memory slips or disorganization.
Yeah, yeah. So how long after that point did it take to get the diagnosis?
So it took about 6 months. We saw her doctor here, Dr. Jeff Williamson, awesome guy. And at the time that Rebecca began to have symptoms, she had just lost her older sister to colon cancer. They were kindred spirits, and Dr. Williamson thought that this maybe was just depression. And because depression is the most common cause of reversible memory loss. And so he treated her with antidepressants over about a 6-month period and said, if things don't get better, let's go ahead and do a more formal evaluation for cognitive function. And things didn't get better. And then she had that evaluation back in 2007.
You just said something that I've never heard before, that that there can be memory loss, reversible memory loss due to depression. It's funny, I've never heard that before with all the interviewing I've done in this area.
Yeah, it's a very important thing to understand. I've changed what I do as a doctor to now dementia diagnosis and care. And so when you see a patient who has new onset memory loss, really there's a couple of important things you have to rule out that are reversible causes, because it's a really big deal to tell somebody you have Alzheimer's disease, or some other dementia.
Yeah.
These, like I said, they're irreversible, ultimately fatal diseases. And so the most common cause of reversible memory loss is depression. And perhaps it's the apathy that goes along with people who have depression, where they just don't put out the effort to remember things.
Yeah.
And so if you treat their depression, you may have somebody who tests in the dementia range on a cognitive function exam, who then tests in a completely normal range. I've had this happen in numerous patients.
That is fascinating.
So, and then the most common medical cause of reversible memory loss is low thyroid. And so there's just a number of medical and mental health diagnoses that have to be considered for someone who has memory loss, because you don't want to treat somebody for Alzheimer's disease if all they need is a thyroid pill or an antidepressant.
Yeah. So are you now in the role of being that person who says to someone, "I'm sorry, but I'm afraid you've got Alzheimer's"?
Yes, so that's part of the work I do now is on the physician side of what I do is dementia diagnosis, and the other half of what I do is more in the counseling side.
Yeah, wow. It seems both ironic and wonderful in a way, because what better person could there be than you to break that news to someone?
Yeah, and for the most part, I don't tell the patients I see that I've been on the journey. Although now people have seen the book or they've read the book, and they come in and say, "Oh, you're the guy whose wife has Alzheimer's disease." Um, but having walked the walk, I think, has resulted in an empathy for people who are, in the beginning steps of that journey that's maybe different for others who haven't walked that walk.
Oh, I would think so. So, what was your marital relationship like, up until that point?
Mm-hmm.
Because marriages differ a lot in terms of closeness and dynamics and so on.
Rebecca and I had an unusually wonderful relationship. We met our sophomore year of college. After 3 weeks of dating, we decided we were going to get married.
Wow.
We talked about having a family and wanting 3 daughters, which is actually what happened.
Wow.
We had a wonderful partnership in which, though she had a career, she was a speech pathologist, master's trained in speech pathology, and worked through the birth and the first few years of our second daughter, Leah. She eventually retired from work and was an at-home mom, and really organizing the life of 3 busy daughters, as well as 1 busy husband who is practicing, teaching, research grants, traveling. I travel quite a bit, lecturing around the country and around the world. And we had a wonderful thing going. We were very close in terms of just physical touch. So we held hands a lot. We were arm in arm. We had a wonderful, intimate relationship together. And it's interesting. You asked me this question, and it reminds me that one of the early symptoms I had noticed, maybe about the time that our daughter was planning her wedding, is I felt a distance between Rebecca and I. Maybe less receptivity to some of the hand-holding or, the snuggling that we would do. And just at this past summer's International Alzheimer's meeting, one of the big messages of that meeting from research was that often Alzheimer's disease, one of the earliest symptoms, will be very, very subtle changes in the individual's personality. And looking back, I think this was true with Rebecca.
Mm-hmm.
But getting back to your question, we had a wonderfully close relationship. It was a back and forth relationship. But as her disease progressed, her ability to express emotion was really gradually lost as she lost cognitive function.
Yes, yes. Now, you mentioned how that there was no emotional support eventually when you received this diagnosis, and there was a lot of pain and disorientation in the family. What sorts of emotions did you go through when you found this out?
Yeah, I think initially the emotion the girls and I felt was just confusion and disbelief. How could this wife or this mom who, really had been sort of a rock star, all-star performer of a wife and a mother, develop this disease that, even somebody who casually knows the diagnosis, Alzheimer's disease, it brings a certain image in their brain of maybe a little old white-haired lady, crouched over in a wheelchair at a nursing station. And yet in the beginning, Rebecca looked very she was physically healthy. She looked like Rebecca always looked. And yet there was this time bomb exploding that was going to explode in her at some point. So I think those were the initial feelings that we had. And then I think as the disease progressed, I say that Alzheimer's disease for the care partner and the adult children, it's like the Chinese water torture of grief, because you see bits and pieces of the person being lost, and you begin to mourn those bits and pieces. And so, I think as the journey went on, our feelings more changed to just, profound sadness and grief over what we were seeing, and then eventually anticipating that we would lose her one day.
Yeah, yeah. Now, you mentioned that you do Alzheimer's counseling now in addition to the medical side. Did you or your family receive any sort of counseling or psychotherapy around that period?
So that's an interesting question. So I went on to receive a master's degree in mental health counseling and left the field of radiation oncology and brain tumor treatment. And then as part of my training, I had psychotherapy, which was required. And then I've continued to see a therapist through the journey, who's a wonderful guy who I just couldn't imagine not having the support of somebody that, I also as a therapist could engage in. And all three of my daughters still are involved in therapy. We all take antidepressants. And I think the intentional mental health care has been absolutely critical to our individual mental health.
Well, thank you for sharing so candidly. Well, I remember now. In addition to that, was there any shared religious tradition that provided support?
Yeah, so Rebecca and I are people of faith. She was a person of very strong faith. She grew up in the church, but I think through a couple of different health care challenges that she had in her life, our faith really developed and became strengthened. And a lot of our support was from, family, but particularly from friends through our faith community that walked alongside of us, Rebecca and I and our daughters, through this journey. And they were very intentional about supporting us. I think for my daughters, my oldest daughter, Erin, is also a person of very strong faith, and her faith has been challenged, but perhaps strengthened through the journey. My middle daughter, Leah, is maybe returning to her faith, though she's still questioning. And my youngest daughter, Carrie, who's is maybe the scientist of the three kids, most like her dad in a way, has really struggled on the faith side and wondered, has had trouble reconciling how could a good God or a powerful God allow a mother as wonderful as my mother to get this disease.
Sure.
And though she and I differ in our faith perspectives, I understand her struggle. I empathize with that, because it is even the person of strongest faith will be broken in parts of this journey.
Mm-hmm. The subtitle of your book is The 5 Love Languages and the Alzheimer's Journey. And what can you tell us about the 5 love languages? What are the 5 love languages?
Sure.
How would you get involved with that?
Thank you. I'm sorry I interrupted you. The 5 love languages is a framework of marriage counseling that was developed by Dr. Gary Chapman, who is a pastor and a marriage counselor at Calvary Baptist Church here in Winston-Salem. And
one of the co-authors of the book, I might add.
He is, and I have to say, he's really the senior author of the book, whose framework we built our philosophy on. Debbie Barr, who really wrote most of the book, and the book is in her voice, is a master's trained health educator. So we each brought unique strengths to the writing team, but Gary brought the 5 love language framework. And nearly 25 years ago, through many years of marriage counseling and seeing couples struggle, he developed this framework of 5 love languages, which are sort of metaphorical languages that people use to communicate love to one another in a marriage relationship, or really a friendship, any kind of a partnership. And so the 5 love languages are words of affirmation. So essentially what you would guess those were, unsolicited words of affection and appreciation that you share often spontaneously for somebody that you care about. The next love language is quality time. It's giving somebody your full and undivided attention. Again, it may be at a time when they're seeking it, but it may be at a time when they're not seeking it. The third love language is gifts, and not just a monetary gift or a gift that you purchase, but it's a visible symbol of love that could be purchased, but it also could be handmade. It could even be a tangible gift that you would give to somebody, but it's a gift. The fourth love language is acts of service. It's doing something that's helpful for another person, where your intent in that act of service is to lighten the load that they have, their physical load, their emotional load, maybe their spiritual load. And then the last one, which happens to be my primary love language, is physical touch. It's deliberately conveying a sense of presence to another person by reaching over and touching that person. And so those are the 5 love languages. And I think the important principle that Gary would say is that you tend to love others the way you want to be loved. When in fact, what he would say is what you need to do is understand your partner's primary love language and love them in the way that they want to be loved.
Mm-hmm. Mm-hmm. You know, that's a simple but beautiful structure, cognitive structure for thinking about love and friendship and relationships. And I don't think anybody could find anything to quarrel with that.
It's a very simple yet powerful framework that particularly in reading Gary's original book, and then he has a number of other 5 love language applications. But it's been a powerful framework that has really changed relationships and brought them back from sort of the brink of divorce or disaster.
Mm-hmm, mm-hmm.
And,
well, tell us about applying these love languages to your wife's decline.
Yes.
Yeah. Give us your sense of that.
So as Rebecca's cognitive function began to decline, knowing that physical touch was very important to me, so physical touch was one of her primary love languages as well. It was, always very important to both of us. I turned to the 5 love languages early on in her journey because, as you were saying, it's hard to quarrel with any of those love languages conceptually. We had actually been to a day seminar that Gary had given. He had autographed one of his books for us probably 15, 16 years ago. And so we were both familiar with the framework. And I began thinking, how can I be intentional about loving Rebecca through the 5 love languages so that we can maintain what I felt like we were able to do almost till the very end of her journey, which was an emotional intimacy. And so
let me just say, I'm struck by that question that you put to yourself, the self-awareness to say, how can I continue to apply this? That you were able to stand back to some degree from the flood of that you were being swept in like a big tidal wave coming in.
Mm-hmm.
That's just, to me, seems like we always have choice, and but we have to remember that we have choice. And I'm just struck by the way that you were able to step back in the midst of all of that.
Yeah, thank you. I think the word you just used, choice, is very important concept that that we talk about in the book. That the kind of love that is, a spouse or an adult child, or even a friend, if you're just a caregiver of somebody who has dementia, that person over the course of their disease loses the ability to express emotional love to another person. And therefore, if you're going to maintain emotional intimacy, if you're going to continue to love that person, it's a choice-driven kind of love. We use a Hebrew word called hesed in the second chapter of the book. This is really one of the brilliant ideas that Debbie had in writing that chapter. But it conveys an intentional, a sacrificial, a choice-driven love in which you say every day, I choose to love. So in my case, I choose to love Rebecca today because we're married. We took vows to one another, and maintaining a loving relationship between us is important for me. And I believe it's important for her too.
Mm-hmm. Mm-hmm.
So I think for a person who in whom physical touch is their primary love language, this is a really challenging thing, not just for Alzheimer's disease, but for another form of dementia called frontotemporal dementia. And in Alzheimer's and frontotemporal dementia, as the patient with the dementia, the person begins to emotionally disconnect. You as the care partner have to then become intentional about reaching out and connecting to that person. So for Rebecca,
so there's not that reciprocity that we normally rely on that says, yes, my love is being received, I'm getting the same thing back.
Yes, and so the reciprocity, it's still there. It changes tremendously. So maybe a more typical marriage relationship unaffected by Alzheimer's disease, reciprocity might look like, on a weekend evening where you've got some time together and you have, a lovely dinner with a bottle of wine. That reciprocity may be, heading off into the bedroom and making love that night. Late in the journey with Alzheimer's disease, the reciprocity may be a nod or a smile.
Mm.
So it's the magnitude of the reciprocity diminishes greatly over the journey. And yet you as a caregiver have to learn to become just very sensitive to even the smallest sort of hint that person still loves you, has that emotional love bond.
And I guess when you do see those small hints, that it's very rewarding to you.
It is.
Yeah.
Sometimes a smile can propel a person through a week of difficult caregiving. Mm-hmm. Just one smile in return.
Right. Yeah, we've heard from so many quarters that being a caregiver is very stressful. And one of the biggest stressors that a person can have, and that all sorts of bad consequences later happen to many people who are in that caregiving role. It sounds like the approach that you took has some built-in protections in a way for you. Mm-hmm. Can you talk about that a bit?
Yes. Well, I think, David, you hit on an important concept in this when you were asking about, did I or did our family receive therapy, and sort of were we intentional about our own emotional care and protection? It is a very difficult journey to be a care partner. It's difficult physically, mentally, spiritually, and as I said, it can break the strongest person at certain points. But yet, if you are intentional, whether that's having a paid therapist, who can be a neutral sounding board for you, or whether you just have a, a close sibling or a close friend or colleague. You have to be intentional as a care partner to create a team around you that's going to help fill your so-called emotional love tank. It's absolutely essential. And this is one of the points we make in the book, in sort of the middle chapters of the book, that caregivers have to be very proactive.
Yeah, yeah. Without trying to be too Pollyannish about this, I'm wondering if it's possible to look at your caretaking journey with your wife as a spiritual journey.
Yes, I think there's no question that the whole journey that she had, that we had, she and I, and then our daughters and I had, was very much a spiritual journey. I think for me, one of the struggles that I had, and one of the struggles I continue to have, is, here was a woman who I loved from a young age, just 19 years old when we met, had a wonderful life together, 3 wonderful children. I don't think that there could have been sort of a better life that you could find out there for the life that Rebecca and I had with our girls and our family and our friends. And so, that same God who sort of blesses you, on the other hand, you have to say, well, is that the same God who allows something bad to happen in the life of somebody good? And so I write about this in the last chapter of the book, that for me, there's not sort of a rear mirror God and a front windshield God. The same God that blessed us has to be, to me intellectually, the same God that allowed Rebecca to have this disease. And so this is where trust comes in and faith comes in. So I still struggle with trust and faith, but have come down on the side of saying, yes, I am going to trust and have the faith in God that, he knew that Rebecca was going to develop this disease. He knew our family would be there to care and love for her, and that somehow some good would come from that.
Well, that raises the question of whether or not this shared dilemma, disaster, brought you and your daughters closer.
Mm-hmm. I think without a doubt it brought the girls and I closer together. I have to give credit to them. They're 32, 31, and 29 now. And very early in the relationship, they did something that was really helpful, which was they metaphorically hit their dad over the head with a baseball bat.
How so?
Well, I remember we were at a family reunion and staying in a hotel, and this was early in Rebecca's journey, and I had felt as their father, and particularly I'm somewhat of a sort of controlling type A kind of guy, that I had to protect them from the reality of the pain of the ongoing journey, and ultimately, the loss of their mother. And so I tried to take their burden in my backpack, so to speak. And I remember we had a conversation in a hallway in an Embassy Suites hotel, and the girls sort of sat me down in the hallway and they said, "Dad, you can't do this yourself. We are as much a part of this journey as you are." Mm. And it was a relationship changing moment for us. But it's really where, my kids stopped being my kids, and they became equals in a sense of we all needed to share on the journey together. So I'm very grateful to them for that moment.
Yeah. And I would think that this experience would also maybe deepen your sense of life, deepen your connectedness in a way to life, even as you struggle with faith, as you say, and with trust. Still, I'm guessing it would put you in touch with something about the preciousness of life, and that this is part of the whole journey, that we all have to deal with these sorts of issues sooner or later.
Yes. There's a quote that's attributed to Helen Keller that says, "The only way to the other side of pain is to walk through it rather than around it." And in the counseling part of what I do, I see so many people who are walking around the reality of the pain of the ongoing journey, and then the reality of the eventual loss. In fact, I did a support group this morning, and we've lost three individuals, partner spouses of people in our group in the last 3 months. And the group members were saying, well, you need to start a grief support group, because we need the experience of sharing our grief even after we lose our loved one. But to get back to the question you asked, I think you do, as a care partner, you undergo a tremendous personal transformation. And I think it's deferred by going around the pain. It's accelerated, though difficult, if you walk through the pain. And I think when you asked that question, what came to mind more than any other one thing is that I became very aware of the sense of time, and that there was a clock that started ticking. Now, of course, we knew that Rebecca's life expectancy would be, for somebody with early onset like her, on average 5 to 7 years, maybe, on the longer end, 8 to 10 years. She lived 9 years, almost 9 years to the date of her diagnosis. And so there's always this sense of the clock ticking, and the feeling that when you take a break from caregiving, you feel guilty because you're not there. But sometimes in the midst of caregiving, you're going crazy because it's so hard.
Mm.
And so you become just aware of things, of your own personal time, and then the amount of time you have left with your loved one. That for me, it became something I thought about every day of her journey after the diagnosis.
This would be a good point to ask you if there's any kind of general advice that you would give to caregivers, because I'm sure in my audience there are people who are probably in that role, maybe not in relation to Alzheimer's or dementia, but even other things.
Yeah.
What sorts of generalizations can you make?
Maybe 3 thoughts. I think, as you implied, I think these thoughts could be true really of any chronic disease, and for a person on that journey, as well as Alzheimer's disease. But I think Alzheimer's is a little bit unique because, in any other disease like cancer, let's say, my former profession, most people underwent a physical transformation, but maintain their cognitive function, often through the end of their journey with cancer. Whereas with Alzheimer's disease, the person is losing their core, their, the cognitive functions that, in a sense, make up their personhood, their personality, and who they are. But I think one of the messages I'd want to say to people is, on any journey like this, you really can maintain a loving relationship with the person, no matter what they're dying of. And that you, as the care partner, take a greater burden of responsibility for maintaining that love, but it can be done. And there's a fellow whose a book I read in medical school, a psychiatrist named Avery Wiseman, and the title of his book was Hoping is Coping, or Coping is Hoping. I don't remember which direction it went, but that there really is hope. Even though sometimes people hear a diagnosis like Alzheimer's or cancer and they feel hopeless. And so I think specifically for someone on the Alzheimer's journey, to realize that the person with Alzheimer's disease, and this is really true of almost all forms of dementia, maybe with the exception of that frontotemporal dementia, that a person with Alzheimer's maintains their ability to receive love. They maintain the ability to receive love really all the way through the end of their journey, even up until death. And I think that this, just remembering, this is a fact that I've observed in counseling hundreds of families and now caring for hundreds of dementia patients and families, that the person with the disease can receive love almost to the very end. And so I think that's another sort of statement of hope. And it reminds me of a story. I'll come back to that if we have time. And then the third thing is that it's something that, an observation you pulled from the discussion, David, and that is that you have to be intentional about loving the primary care partner. You have to be intentional about being a team and being proactive about who has what job on the team.
Mm-hmm, mm-hmm. Well, we do have time for the story. Go ahead before you forget the story. I know I would throw something like that out and then later wouldn't remember what the story was. So let's grab it while we can.
Sure. Well, the story, thank you for allowing me to share the story. One of the common things that we hear among family members, and this is particularly true in the younger individuals we counsel. So yesterday, in fact, I had a couple come in. I care for the husband who has early onset dementia. He's a bit older. He's 10 years older than his wife. And so they married late in life, and they have triplet boys that are 13 years old. Mm. And so he came for his medical checkup, and the boys came to see one of my counseling colleagues. And, and so we have middle school and high school age kids who are care partners or caregivers for their grandparents or maybe their parents. And one of the things that they'll often say is, why should I bother going? They being, grandma or grandpa, they don't even know who I am. They don't even acknowledge when I'm there. And so the story that comes to mind is I once counseled a pastoral counselor, and he came to me and he said, I as part of my ministry, I go to hospitals and nursing homes, and I have a number of individuals, from our congregation who have Alzheimer's disease. And I go there and I sit down. The person doesn't even acknowledge that I'm next to them. And after about 120 seconds, I'm fidgety. I'm looking at my email and my text. And about 5 minutes later, I get up and I go, never having really interacted, because I say, what's the point? And so I think this is a common sort of mindset, and I don't say it in a negative sense at all, but often when we go visit somebody who maybe has a grandma or grandpa who has dementia, you're going there hoping to have this wonderful interaction, and to say, oh, I visited them and we talked about old times, and golly, it was great to feel the old spark again, but that may not happen. And so in a sense, the thought process that person is going to that interaction is, I want to get something out of the interaction. So it's one where the mindset is more what you're going to receive. I think what we try and say in keeping love alive is you can use the simple toolkit like the 5 love languages to really minister to a person, to love that person overtly. So I said to this fellow, we had a couple of sessions where I had him read the 5 love languages book and use these love languages intentionally in his ministry, that he could go and share some words of affirmation. So Mrs. Jones, it's great to see you today. Looks like you're resting comfortably. Let me just open my Bible and share some scripture for you. Let me read a couple Psalms to you. And she may never flinch in hearing those things, but more often than you would expect, there might be a response there. I said, you could also, words of affirmation includes music. Music is a wonderful form of affirming words. And we talk about the therapeutic nature of music in the book. And this has become very sort of popularized by the Glenn Campbell special that was on TV 6 months or so. His family's been very public with his journey. But the pastor could use singing words of affirmation to maybe sing a familiar hymn or two. And music can actually literally, transform somebody who seems comatose and they wake up.
There was a film about that, a documentary.
There was.
It was so inspiring where they would put some earbuds on somebody who, as you say, they looked like they were comatose, and they came to life, and it brought back all sorts of memories for them. Yeah.
Yes, I think the documentary was called Alive Inside, and if you Google Henry's story, you'll come to that YouTube segment. It's about 8 minutes. It's wonderful. But really just the act of, say, sitting with somebody to say, well, I'm going to spend 20 minutes there, and I'm going to hold their hand. That would be physical touch. And really, it's not going to be about what I get from holding their hand and spending time in touch with them, but maybe what they're gonna get from being touched. You might rub their elbow or their shoulder, and so these are a couple of gifts.
And I think that becomes that person, the caregiver's spiritual practice. If one could look at it that way and say, this is my spiritual practice, just like meditation would be a spiritual practice, to be in this mode of giving. Yes.
And this, so this was interesting in our family. It played out a bit differently with our daughters. My oldest daughter, Erin, learned to love coffee from her mother, and one of her favorite things all through the journey to do with Rebecca was to just sit and have a cup of coffee with her. Mm-hmm. My middle daughter, Leah, is a musician. And so she's a singer-songwriter. And Rebecca loved hearing Leah play the guitar. In fact, Rebecca, 3 years before she died, lost track of that Leah was her daughter. Mm-hmm. She could remember the lyrics to Leah's song.
Wow.
Even said to Leah something like, I had a daughter that sings like you.
Wow, yeah.
And so that was kind of Leah's love language, was the music with affirming words.
Sure.
Erin was quality time with a cup of coffee. Carrie, my youngest daughter, would sort of sit on the couch and wrap her arm around her mother's arm and kind of rest her head on her mom's shoulder. And it was more the physical touch, maybe even more so than words, was just the physical connection.
Mm-hmm. Mm-hmm.
So I think you can really be intentional about loving somebody through the gifts. And these are just some examples.
Are there instances where the person suffering from Alzheimer's or dementia, their personality takes a nasty turn? Somehow,
yes.
That must be extremely challenging if they become assaultive or mean.
Mm-hmm. Yes, in fact, it's interesting you bring it up, because we had that situation come up in our support group this morning, where the person with dementia had become aggressive, and they were yelling, screaming, actually striking out at. They were in a facility. They were striking out at caregivers, striking out at their family members. And so the person who brought this up said, well, isn't there a medication that they can give her just to basically sort of, give her a chill pill to settle her down? But I think when you see these negative behaviors, it's often a knee-jerk response in the healthcare community to medicate the patient. But often who's really being medicated, it's the patient being medicated, but it's so the staff or family have an easier time being around their loved one. So David, you sent me an email when you invited me to come on your show and mentioned Dr. Bonnie Badenoch, who's someone you've interviewed before, who is really well known in the world of interpersonal neurobiology. And we quote some things from Dr. Badenoch in our book, but particularly this notion, this psychological notion of attachment, and that we have attachment figures that begin from infancy. So usually our parents and our siblings. And then, as a teenager, you attach really to friends, to your peers. And then as you go into adulthood, you attach to your life partner. And so one of the things we say in the book is that rather than just a knee-jerk response of medication or saying, I can't deal with this, agitated behavior or crying or whatever, to really ask the question, why is the person having these negative emotions? So in the person who this caregiver was talking about this morning, it was very clear that they were suffering from attachment loss, that the agitated behavior occurred when the family member left the facility.
Mm.
So, what it says to me is I probably wouldn't medicate that person. You're just going to dull their sensorium. And even though the tendency of that behavior is to drive the family away, and it really was driving this woman away, I don't want to go because I don't like when my mother hits me. But to say, rather than sort of being pushed away, try scooching mom over and just getting in bed next to her.
Mm-hmm.
Gently putting your hand on her arm,
Mm-hmm.
and to try and reattach to her. And it doesn't always work. I mean, sometimes you have to use medication, particularly when a person is truly psychotic and they're having paranoid delusions. But much of the time, you can actually use non-medical or behavioral means to deal with these difficult behaviors. We talk about a framework in the book called acknowledgement, affirming, and redirection. So if mom is screaming as you're starting to leave, rather than just, sort of getting out as quickly as possible, you acknowledge and say, oh, mom, I can see, it looks like you're upset because I'm putting my coat on and getting ready to go. I'm sorry. So that's the acknowledgement. And then you might affirm and say, I'm going to miss you. I've got to go home and cook dinner for husband and your grandkids. And I'm going to really miss you while gone. I'll be back in a couple of days. Maybe we can get some coffee. And then you redirect. So maybe now you'd like a cup of coffee or you're ready to go to dinner. Maybe, you can go out to the nursing station and sit and talk with some of the nurses, or go to the room next door to your friend there. But, let's sort of get you set up before I take off for tonight. And so it's, it's an intentional way of sort of disengaging that isn't so traumatically disattaching for the person.
Right. Now, some of these examples you're giving are of a person who is now in a facility. And I'm wondering, did it come to that with Rebecca?
Yes, absolutely. And it was no different than, me going off to work in the morning. There were periods where that was very traumatic for her.
Well, that must have been a very difficult decision for you. Maybe you can walk us through that part of it.
It was a difficult decision to keep working. So I'm almost 4 years younger than Rebecca. And then caregiving is an expensive proposition. The medical care is expensive. We needed medical insurance. There was just a pragmatic aspect to me needing to work. On the other hand, work has always been a way that I derive meaning in life. So the work that I've done in my first career and currently has always been very important to me. And so we were very fortunate through her journey to find some paid caregivers. These were all ladies whose last name ended in A. We called them the A team. When I wasn't home, they were the ladies who took care of Rebecca. And, she was truly 24/7 surrounded by love. She had an uncommon associated condition with her Alzheimer's, where she became essentially cortically blind. She couldn't see very well. And so she couldn't walk without somebody walking at her side. So I couldn't put her in a facility if I had wanted to, because she would have fallen on the first day and broken a hip and probably would have ended her life. So she needed one-on-one care, either from me or from a professional caregiver. So I did work. I took quite a bit of time off, especially in the last year of life, and was very glad that I'm very glad that I did continue to work. And the last 2 years, a lot of time has been spent working on the book with Debbie and Gary, because it's been meaningful. But also, I don't have regrets about not having loved Rebecca to the fullest, because I feel like the girls and I really are extended family and friends, that she really was loved to her last breath.
Yeah. Well, I think we've probably come to the place where it'd be good to close off. I think this book that you've written is really an important resource, going to be an important resource for other people in that caregiving role. And I really appreciate the honesty and courage, actually, on your part to come out and share your journey with Rebecca in such a candid way here and in the book.
Yeah, thank you again for the invitation. Our whole Keeping Love Alive team appreciates it.
Okay, well, Dr. Ed Shaw, thanks for being my guest today on Shrink Wrap Radio.
Thanks, David.